Hi, you're still here. Welcome to part 3 of the appendix. Let's start with the complicated appendicitis. Perforated and gangrenous appendicitis and appendicitis with abscess or phlegmon formation are considered complicated conditions. Patients with perforated appendicitis usually present after 24 hours of onset, although 20% of patients present within 24 hours. Such patients are often acutely ill and dehydrated and require resuscitation. Usually, the perforated abscess is walled off in the right lower quadrant, although retroperitoneal abscesses, including psoas abscess, liver abscesses, fistulas, and pylophlebitis, portal vein inflammation, can also occur when left untreated. Perforated appendicitis can be managed in either operative or non-operatively. Immediate surgery is necessary in patients that appear septic, but this is usually associated with higher complications including abscesses and enterocutaneous fistulae due to the dense adhesions and inflammation. The management of long-duration complicated appendicitis is often staged. Patients are resuscitated and treated with IV antibiotics. Patients with long-standing perforation are better treated with adequate percutaneous image-guided drainage. This strategy is successful in 79% of patients who achieve complete resolution, which occurs more often in lower-grade abscesses, transgluteal drainage, and with CT versus ultrasound-guided drainage. Operative intervention is performed in patients who fail conservative management and in patients with free intraperitoneal perforation. Interval appendectomy. The majority of patients with perforated appendicitis, 80%, have resolution of their symptoms with drainage and antibiotics. There remains debate about the value of performing an interval appendectomy 6 to 8 weeks after the original inflammatory episode. Proponents of this approach cite the incidence of recurrent appendicitis 7.4% to 8.8% and the presence of appendiceal neoplasms detected on the appendectomy. Relevant benign lesions 0.7%, malignant lesions 1.3%. Opponents cite the high incidence of no future events after a median follow-up of 34 months in 91% of patients. Currently, shared decision-making is necessary before proceeding with an interval appendectomy. That's it for the complicated appendicitis. Let's proceed to operative intervention. Pre-operative preparation. Once the decision to proceed with surgical intervention is made, patients can be taken to the operating room rather expeditiously. While resuscitative efforts are important in patients who present with significant dehydration or in a compromised host, the majority of patients can be taken to the operating room within a short interval. Placement of Foley catheter is optional but necessary while performing an appendectomy. Pre-operative antibiotics must be administered at least 30 to 60 minutes prior to skin incision. The choice of antibiotics include cefoxitin, ampicillin sulbactam, cefazolin plus metronidazole for uncomplicated appendicitis. Patients with beta-lactam allergies can be given clindamycin in combination with a fluoroquinolone, gentamicin, or aztreonam. Post-operative antibiotics are usually not necessary. In patients with perforated appendicitis undergoing operative intervention, pre-operative antibiotics are necessary to cover gram-negative bacteria and anaerobes. Monotherapy with piperacillin tazobactam or combination of a cephalosporin with with metronidazole are reasonable choices. The duration of post-operative antibiotics is generally less than 4 days once complete source control has been achieved. Patients with incomplete drainage, persistent catheters, complications from surgery, and uncertain resolution of inflammation might need a longer duration of antibiotics. Okay, so that's it for the pre-operative preparation. Next is operative technique. Open appendectomy. An open appendectomy is usually performed under general anesthesia. Although regional anesthesia can be used, after wide prep and drape, an incision is usually made on McBurney's point either in an oblique fashion or McBurney's incision or transverse incision, which is the Racki-Davis incision. A lower midline laparotomy incision is more appropriate for perforated appendicitis with a phlegmon. A muscle splitting approach can be utilized to access the peritoneum in patients that are well paralyzed. The bed is positioned in Trendelenburg's with a left side down. The appendix is usually readily identified, but if necessary, it can be found by tracing the anterior taenia liberia, of the cecum distally. We generally ligate the mesentery early to allow better exposure. If the base of the appendix is viable, ligating the appendix is acceptable. This can be imbricated with a Z-stitch or purse string configuration, or alternatively the mucosa can be fulgurated. In the event of retraction of the appendiceal artery or unexpected bleeding, the incision can be extended medially using the Fowler or Fowler extension. Skin closure is usually performed in a layered fashion, but in cases with significant abscess and contamination, closure by secondary intention or delayed primary closure has been considered. Recent trials have suggested no difference in surgical site infection rates between the primary and delayed primary closure. Placement of surgical drains has not been proven to be beneficial in multiple clinical trials for either complicated or uncomplicated appendicitis. So that's it for open appendectomy. Next is laparoscopic appendectomy. Okay, patients undergoing laparoscopic appendectomy are positioned supine with the left arm tucked for better access. Monitors and assistants are positioned appropriately. Access to the peritoneum can be obtained using either the Hasson technique in a periumbilical fashion or with a Veress or optical trocar in the left upper quadrant, 3 centimeters below the costal margin in the mid-clavicular line. 5 mm ports are usually placed in the suprapubic and left lower quadrant areas. It is also technically feasible to place the third port in the right upper quadrant. The bed is positioned in Trendelenburg with the left side down to sweep the bowel away. The bed is positioned again with the Trendelenburg and left side down. The appendix is grasped and elevated upwards to identify the window between the mesoappendix and the cecum. Occasionally, it is essential to release the mesenteric attachments of the cecum to mobilize a retrocecal or pelvic appendix. To obtain this view, using a Maryland grasper, the window is created and the mesoappendix is divided with cautery clip or a bipolar energy source. The base of the appendix is divided either with an endoscopic stapler or after placing an endoloop. Again, the base of the appendix is divided either with endoscopic stapler or after placing an endoloop. In the case of a non-viable appendix base, staple line through the cecum that avoids the ileocecal valve might be sufficient, unless significant inflammation is present. The appendix is retrieved through the midline port in a specimen bag, especially if an appendiceal lesion is suspected. If a periappendiceal phlegmon is encountered or if the operation is being performed for perforated appendicitis, careful sweeping of the bowel with a blunt dissector can release the appendix. It is important to carefully separate the adjacent bowel, which can be friable in such settings. Conversion to an open surgery should be considered for failure to progress. Typically, once the base of the appendix is identified, it is generally more helpful to divide the stump first. An endoscopic stapler or endoloop can be used for the base, provided the base is viable. Occasionally, an ileocecectomy. Again, an ileocecectomy is necessary when resection of the base of the appendix or cecum is likely to impinge on the ileocecal valve. The mesoappendix is similarly divided with either a staple with thin leg length staples, a clip, cautery, or energy device. So that's it for this part. We will proceed later for the part 4. Thank you.